Now I would like all the organizers, Dr. Jyoti Shetty, Dr. Sandeep Kamane, and Dr. Prasad Dandekar to please escort our chief guest for lighting the lamp.
Felicitation you can do everyone on the speakers and principal.
Visible in the screen.
Now I request all the four speakers, Dr. Bhushan Shukla, Dr. Jyoti Shetty, Dr. Prasad Dandekar, and Dr. Sandeep Tamane, to please come and take a seat on the chair, to take a chair on the podium. I invite Dr. Mani on stage as well.
Let's just have a small felicitation. I will do the felicitation and then we can start. Just tell them that.
Like screens. If you hold the camera here.
Now I request Dr. Jyoti Shetty to please felicitate our chief guest, Dr. N.S. Mani. I request her to felicitate our speakers, Dr. Prasad, Dr. Sandeep, and Dr. Bhushan Chopra. So without any further delay, I would like to begin with the CME. Our first speaker of the day is Dr. Sandeep Tamane. Dr. Sandeep is a consultant physician and a geriatrician working in Pune since 2003. He is also the current chairman of the Pune chapter of Geriatric Society of India and an executive committee member of the GSI national body. He has been a speaker in various national medical conferences. I hereby invite Dr. Sandeep Tamane to take over the podium.
Just make sure that you're visible in this. Yeah, this yes. It's a short light.
Good morning, everyone. On behalf of the Geriatric Society of India Pune chapter, I welcome you all to this CME today. It is indeed a very special day for us because we are having this first offline CME today after a gap of 2 years. So it is always nice to meet each other, discuss with each other, which we are having today after a gap of 2 years because of COVID. Of course, we did 2 online programs in last 2 years. GSI Pune chapter had a guest lecture by Professor P.A. Shankar, well-known physician and geriatrician on dementia. That was in March this year. And last year in June, on the eve of the Elderly Abuse Day, World Elderly Abuse Day, we had an online program in collaboration with the Janaseva Foundation Pune. But this is first offline program we are arranging here. Now, hopefully COVID will settle down. At least it will not be as problematic as it was for 2 years. So we hope to have regular academic activities offline. And I would invite all of you to join those activities. Today we are having this CME on a very different topic on LGBTQ plus issues. This is a very important and a relevant topic these days. We know our senior member, GSI Pune chapter senior member, Dr. Jyoti Shetty, who is the HOD of psychiatry here at Bharati Hospital. She and her department are providing medical, psychological and social support to the LGBTQ community for a long time here. And when we were planning a CME, an offline CME, this discussion came up that why not have a CME on a very different topic, something which has not been discussed in the past, but at the same time, something which is very important to all of us being practitioners, whether we are practicing or no, we are working in medical colleges. So that's how this CME is taking place. So when we decided to have the CME, we contacted Dr. Prasad Raj Dandekar, who is a radiation oncologist based in Mumbai. And he's also a founder member of the HPQI, the Health Professionals for Cure Indians in Mumbai. And he's doing a lot of work for the community. Dr. Prasad also supported our idea, and he is here today as one of the important speakers for this CME. I am sure this CME will give all of us some insight into the issues related to the LGBTQ community because we hardly know anything about it. And as pointed out by Dr. Jyoti Madam, 5%, which is not a small number, about 5% of the population is in this particular group. So when we are seeing patients in day-to-day practice, we don't know how many of patients from this community we might have seen, but we are not just aware of their problems, their issues. So I think this CME will help all of us, all healthcare professionals, towards building an LGBTQ positive inclusive medical practice. Here I would also like to thank my colleagues from the GSI Pune chapter, Dr. Lata Bhoir, who is the Vice Chairman of the GSI Pune chapter. Dr. Surekha Chawhan, she is not here today, she is the Secretary. Dr. Smita Athavale, who is the Joint Secretary of the GSI Pune chapter. She's also in UK at the moment, so she could not come. Dr. Kakrani madam is here. She's also a very active member of GSI Pune chapter. So I thank all of them, all my colleagues from the GSI Pune chapter for helping us to organize this CME. And see, it doesn't matter. The crowd is less. We don't have enough delegates, but this is a beginning. And I don't think anyone else in Pune from the medical fraternity has done it. API would have been another platform where this issue would have been discussed. But we are glad that the GSI, the Geriatric Society, is taking up this chapter, this topic. And in future, we will definitely have more CMEs on this topic with involvement of speakers, doctors related to this particular issue who are working on this issue. And definitely we'll get a better response this time. So I thank all of you once again for coming here today. We have 3 excellent speakers, those who are working quite actively in this issue, in this field for a long time. And this will definitely help to sensitize all of us to this problem. Thank you.
Thank you, Dr. Sandeep, for the introductory lecture. The next speaker of the day is Dr. Prasad Raj Dandekar. Dr. Prasad is a radiation oncologist who is trained in Tata Memorial Hospital. He is the current head of the Department of Radiation Oncology at Sir H.N. Reliance Foundation. He is also the founder of HPQI, Health Professionals for Queer Indians. Please welcome on stage Dr. Prasad Dandekar.
So first of all, thank you very much, Dr. Jyoti Shetty and the team at Bharati Vidyapit for organizing this event. Actually, I don't need even a mic. We can all come together. I don't think we need backbenchers. Come ahead, come ahead. We can all fit in the first 3 rows so that we'll have more intimate discussion. So thank you very much for the Bharati team and Dr. Shetty's team and the department for taking this initiative in organizing this event. And as Dr. Sandeep mentioned, this is one of the first ones being done, in the medical college and on these topics. And I want to refer back to what Principal Mani said about not needing these labels. Currently, we have this label of this community of LGBTQ plus individuals. I remember around 10, 12 years ago when I went to Sweden. Normally when I travel, I always like to, first of all, I identify myself as a cisgender gay man, and we'll talk about what is gay and what is cisgender as we go forward. I always like to go to the gay district of the city, visit some gay bars and, see the culture as such they call it. And I was horrified when I went to Stockholm. They didn't have any gay bars. I said, what the hell? I mean, I'm in a first world country without gay bars. And, so I actually searched high and dry. And then I spoke to someone who lives there and he said, we don't need gay bars. If you want to have a drink with a friend, you go to a bar. Why do you need a gay bar? There's no need to, segregate people and create ghettos. And that is the vision that I have, that one day in India, we would have that sort of a culture where we don't need to identify ourselves by how different we are from each other, but rather identify ourselves on the basis of how similar we are with each other. So on that note, let me just share my slides. And the problem that Dr. Sandeep mentioned is a problem which is really a big problem. And the problem is that the doctors don't know how to treat their LGBTQ patients. Does that mean that LGBTQ people need treatment? Absolutely not. When we say treat LGBTQ people, means that when a person from the LGBTQ community goes to a doctor for any health condition, like any one of you, then what happens? So the idea is to train the doctors on those. And why do we need to do this? As medical students, as doctors, we are to a certain extent trained on, our how to be compassionate with our patients. And we know these words, sympathy, empathy, and compassion. What we many a times forget as to our compassion and sympathy and empathy are not absolute. Sympathy is when suppose if I fall down from here, you will say, oh my God, are you hurt? Are you feeling sorry for it? Empathy is when if I fall down, you will come next to me and you will sit down with me and, actually feel bad that I'm hurt. And compassion is when you will actually get an ambulance for me. Okay, I don't need somebody sitting here with me and, crying with me. I need action. And that's compassion. Interestingly, our compassion is not absolute. In the ideal world, yes, but it's not absolute. It depends on many factors. The first factor is clinical factors. What are the clinical factors? Do you like the condition that the patient has come to you with? You are a psychiatrist and you don't like really people who are severely depressed. Your compassion level may be low. Maybe you don't like schizophrenics. Your compassion level is going to be low. Maybe if it is a very complex presentation, your compassion level is going to be low. You're going to say, let me sort of get done with this. Let somebody handle this. How badly behaved the patient is or how well behaved the patient is or the patient's family is has a huge impact on how we feel about that patient. We always are nice to people who are nice to us. And then there will be patients who are unruly and there will be patients who are very different than us. How many times do we feel people who dress differently than us are different? Somebody comes in with a complete hijab, or somebody comes in with very traditional clothes, or somebody comes in with a very short skirt. You notice it. And you notice that they're different from you are. Doctor's factor. Where is the doctor trained? What has been the life experiences of the doctor? Has doctor been trained into treating these types of patients? Has he always had patients who are nice to him or her or them, or they've had patients who are generally very, very ill-behaved? That will impact. And of course, the environmental and institution factor. Does the institute sort of allow you to be compassionate? So I trained in Tata Hospital. And as a resident, we would typically be 3 residents in an OPD and at least 60 to 70 patients waiting outside, and we would have 3 hours. I didn't have time. Maximum I could give is 2 minutes per patient, and that would save their life. If I give them those 2 minutes, they will get on to treatment and they will not die. If I spoke to each of them like I do currently for 45 minutes, I can probably treat 5 patients and rest of them will die. So my organization is not allowing me to be compassionate to the patient. Now, why these factors are important is that we need to be aware that our compassion is not absolute. It is not an endless pot of compassion. Once you become aware, only then can you transcend it. When you identify, oh, this person is a little different, I don't really like him, but as a doctor, I'm going to do the best for this person. But if you're not aware of this, you will probably just miss it and you will treat that person wrongly or badly or poorly or whatever that may be. And why is this important in this conversation is that many a times people who come to your clinic will look, feel, talk, or have life experiences which are very different than yours. You will have a person who will walk into your clinic and say, I have STI, my boyfriend also has STI, what do I do now? And at that point, if you sit in judgment of, my God, this guy has an STI and now he also has a boyfriend, I don't really want to treat him. So I want you to be aware that your compassion is very variable, and you as a physician, after taking the oath that we did take, has the duty and responsibility to transcend it and move forward. I want to introduce you to certain terminologies about the LGBTQ community as such. Now, there are multiple, labels into it, and, it's an endless list. And I'm going to talk about only a few which you will, as clinicians, come into your practice. But before that, we need to talk about sex. What is sex? Sex is basically assigned at birth, and it is based on the appearance of the external genitalia of the child. And if they are ambiguous, then we depend on the internal genitalia, chromosomes, hormonal sex. So it's a physical, biological, and chemical makeup of that particular individual, which is very different from gender. Gender is the attitudes, feelings, and behaviors of that individual in a given culture. To give you an example, if I came today wearing high heel leather shoes and a nice, beautiful skirt, you will feel a little shocked. Oh my God, what is this guy doing here? You know, this is so inappropriate, this, that. If I do the same in Scotland, that's a very macho thing to do. That's what Scottish men wear, right? So it is cultural, and it is also what the person identifies themselves as. So gender is, first of all, very complex, and it is not binary. So it's not like male, female, or male, female, transgender. It is a very complex structure, and there is nothing like biological gender. Gender is not biological. Sex is biological. Now, how do you know when a person walks into your clinic, what gender are they? Any guesses? Exactly. Ask. Okay, just ask anybody, what is your gender? They may say, I identify as male, female, agender, whatever they may be. You just ask, you don't presume. The difference between gender and sex is that the sex is biological, gender is socio-cultural, sex is from nature, to say so, and the gender arises from the society. The society sort of doesn't give you gender, but it arises from the complex interaction of the individual with the society. Sex, as I said, is chromosomal, so it is constant, while gender can be variable. Today, I identify myself as a man. Going forward, I may not do so. I may want to identify myself as a woman. You never know. That would be fantastic, actually. I think women are far better than men. Sex is based on chromosomes, internal and external sex organs, and gender can change with time and culture. Now, gender identity is the next level we need to get into, where it is a person's deeply felt inherent sense of being a boy or a man or a girl or a woman, and it may not correspond to the sex assigned. So, for example, you may have a boy who may identify themselves as a girl or vice versa. So that is the identity that that individual is identifying with. Again, as you rightly said, the only way to know what gender they identify with them is to ask. Many of us get very confused between sex, gender identity, and sexual orientation. And these are all very, very different concepts. Now, sexual orientation is an identity of that individual's where that person's sexual and emotional attraction to another individual. So that person could feel attracted to men, women, both, neither, or to people who are genderqueer, and I'll come to genderqueer, androgynous, or other gender identities. Again, sexual orientation is something which is not visible. The only way to know what is the sexual orientation of that person is to ask. So that brings me to what is cisgender. Cisgender is a person who identifies as with the sex that they are assigned at birth. So I identify myself as a cisgender male, which means that I was born as a boy with external, internal, and chromosomal identifications of a man, and I identify myself as a man. So I'm cisgender, and then I'll come to transgender later. Now, heterosexual is a terminology which is used basically for people who are emotionally, physically, and or sexually attracted to people of the opposite sex. In common parlance, we call it people who are straight. I particularly don't like this word straight, and many of my straight friends also don't like it, but we don't have a better word for it. So, heterosexual or straight people. Now, there is also a terminology called as heteronormativity. And that arises from the fact that heterosexuals are, of course, in majority. So 95% of the population may identify themselves as heterosexuals. So these are men who like women, women who like men, and they are in majority. So the problem is whenever we have a majority, the majority is blind to minority, right? For example, we have this fantastic auditorium. It is made for people like you and me. It is not made for people who cannot walk. Majority blind to needs of minority. And this is what happens. I don't think any one of you notice that there is a no ramp here. And this is exactly what happens. That because we are so focused on our life and everybody around us is like in majority, you don't think about the minority. And this is just a small example. Now, that brings me to the minority. Homosexuals are people who are emotionally, physically, and sexually attracted to members of the same sex or gender. So I identify myself as a homosexual man. I'm attracted to another man. Now, this term is sort of, medically also and socially also, we don't really use this word as homosexual because there is a history of this word being used, medicalized and being used in the wrong context, that homosexuality is an illness. So in common parlance, you would say that person is either gay, or you could say that they are queer, or homosexual. There are other words I will talk to you about later, which you should not use with your homosexual friends or patients. Lesbian is a woman who emotionally, physically, and sexually is attracted to other women. And gay, as I said, are men who are primarily emotionally, physically, and sexually attracted to members of the same sex or gender. Bisexuals are a very curious lot. Okay, they are universally hated because straight people feel that they're taking advantage of women, gay people feel they're taking advantage of men, and there is a lot of biphobia, but bisexuals exist. Now, these are people who are emotionally, physically, and sexually attracted to people of their own gender and the other gender. And then people say, oh, you can't have it all. This is not fair. How can you do it all? But, there are people who feel like that way. Now, it is not 50-50. If you're a bisexual, doesn't mean 50% of the times you're attracted to men and 50% of the times you're attracted to women. It can vary with circumstances, individuals, your phase in life, and it can vary. So be wary of this biphobia that exists quite rampant in even the LGBTQ community. Now, we talked about cisgender. I said I'm a cisgender individual. We talk about, sorry. It is on Zoom. Okay, I'll do that. I'll stop and share. Okay. Yeah. So transgender individuals whose gender identity does not conform to their sex that they were born into. And then a trans man is a person who was born female with female genitalia and chromosomes, but identifies themselves to be a man. And and a trans woman is somebody who was born as a male, but identifies themselves as a woman. Now, in the Indian subcontinent, within the trans women group, we have a specific subgroup which has religious as well as cultural context, and that is called as the Hijra community. Hijra community is a part of transgender community. Not all Hijras are all Hijras are part of the transgender community, but not all trans women are Hijras. Okay, Hijra is a specific religious and cultural group, and there are many trans individuals like the one in the lower photo. She's a friend of mine based in Pune. She does not identify herself as Hijra. She identifies herself as a trans woman. Bi-curious are people who are curious about their sexual orientation. Now, we need to remember that our sexual orientation and gender identity is what we call as fluid. It is going to change. It is not binary. There are no boxes to be ticked. there is a fluidity amongst it. People will have experiments, people will shift over a period of time, and we need to be cognizant of the fact. So you may have a patient in the clinic who got married and then comes to you, 10 years later and says that, you know what, I have just been starting to feel differently, and I had a sexual sort of episode with another man, and now I think I'm bisexual. That is real, that is possible, because people can then shift over a course of their life and their sexual orientation. Just like bisexuals, which are a bit of a unicorn for many people, asexuals are like, my God, how can there be anybody who's asexual? But they also exist. These are people who experience little or no sexual attraction to others. And there's nothing wrong with them. They are fully functioning, adults, and they're fine. You don't need to treat them for asexuality. Their asexuality is as real as our hetero or homosexuality. Now, asexuality is very different from celibacy. Celibacy is where you are feeling an attraction and you are suppressing it and saying that, okay, I will not do these acts. That's very different. These people genuinely do not have any attraction to other individuals sexually. And then there will be questioning individuals who are again going through a phase and they are unsure about their sexual orientation. Now, queer is a terminology which is sort of an umbrella terminology, which contains all these labels that I spoke about. Now, queer, as you understand, as an English word, is actually a derogatory word. Queer means something which is odd, something which is weird, something which is abnormal almost. And this was a derogatory word used for the LGBT community until a few decades ago, and the community sort of adapted that word and normalized it, and we started calling ourselves queer. So it's an umbrella term that is used now. So there are people who are genderqueer who do not align with any binary understanding of the gender. And then there are so many different, logos for this. Now, there will be a number of men, especially in the Indian subcontinent, who will say, I have sex with men, but I'm not gay. Okay. And the logic there is that I only do penetrative sex. I do not get penetrated, so I'm not gay. And that logic is a little twisted, but that exists. And these people are then called as MSM, men who have sex with men. And this terminology has primarily come from the HIV era, where you had a lot of people who had HIV or were passing on HIV, but were saying we are not gay. So we had to come up with this terminology called MSM. Androgyny or androgynous people are, where people express their gender as the elements of both masculinity and femininity. And you sometimes may wonder, looking at them, you may not be able to understand their gender. And again, the only way to figure out is to ask them what their gender is. Now, there are some words which you should not use. Okay, you have a person who walks into your clinic and, she says, I'm a lesbian. And now, dyke is a word which is used for lesbians. It's, masculine lesbians. It's a derogatory word. As doctors and as allies of the LGBT community, this word you should not be using. Another word for gay men is faggots. It's a derogatory word. Faggot is a word that comes from the fact, faggot means a bundle of sticks. And it comes from the fact that gay men should be burnt at stake. And the faggot word is a reminder that we will burn you down and things like that. So these are words which you should not use. I can use, I call my friends faggot, but you can't. What we are doing through these seminars that we are organizing is building an allyship. People who do not identify themselves as the member of LGBT community, we want to bring them on as allies who are supportive of the LGBT community and who will help us to thrive. So I hope that people who are attending online and people who are attending in person, the aim at the end of the seminar today is to have a strong allyship built. And the role of the ally, I would see, is not only being there for members of the LGBT community, be it your friend, family, colleague, or whosoever, but also being vocal. Now, Dr. Bhushan is going to talk about coming out, and when an LGBTQ individual comes out and tells about themselves to other people. I urge all the allies to come out. Come out in open and say that I'm an ally of the LGBT community. The more people do that, we will have more and more support for the LGBT community, where we will have, and the major problem that we face is the discrepancy in the healthcare access for the community. So we want allies from the medical fraternity to come forward and be there for the community so that we can achieve the target of equal healthcare for everyone. This is my last slide. A couple of last slides is about heteronormativity. And this cartoon actually summarizes it all. So I get questioned many times, so who's the woman in the relationship? Because the normal thing to do is there is a man and a woman. So if there are two gay men together, I've been in a relationship for 18 years. And even now we get called. So who's the woman in the relationship? The whole point is that there is no woman. Okay. So that is the heteronormative thinking. Who does cooking? Anybody could do cooking between two of us. People ask questions like, very, very basic things about, what you do, what do you do in bedroom, what do you do in social circle. Everything is based around this heteronormativity. So we need to be, aware of this concept that not everything that happens needs to be along with heteronormativity. I'm going to also bring forward a slightly controversial topic here of, again, heteronormativity is open versus closed relationships. Now, and marriage. Marriage is traditionally labeled as a man and a woman marrying and then continuing to have sex. There are, many relationships where people are open in their relationship, which means they could have, sexual relationship with every, other people. So the rules of heteronormativity don't really always apply to LGBTQ community and many other incidences as well. So we need to be mindful of those differences as well. Homophobia is a complete misnomer. Phobia is fear, and homophobia is not fear. Homophobia is hate, negative attitudes towards people of the LGBTQ community, and it denotes fear, disgust, dislike, and also sometimes physical violence, emotional violence, verbal violence. It is not fear, it is hate. And that is something through these educational seminars, we will be able to, overcome. In fact, the initiative which I started of Health Professionals for Queer Indians actually emerged from homophobia. I got a very bad homophobic attack on social media by a colleague of mine, which became very difficult for me to emotionally handle. But then over a period of a couple of years, I realized that actually the guy who did it is a nice guy, and probably he did it because he was ignorant, and here we are today. Dr. Bhushan is going to talk about coming out, so I'm going to completely skip this slide, and I'm going to end here. Thank you very much.
Thank you, Dr. Prasad. As a young psychiatrist, just getting into the field, you have given me a lot to reflect upon. I think for a few minutes, if anyone has any questions, then I ask Dr. Prasad. So our next speaker of the day is Dr. Bhushan Shukla. He is a practicing child and adolescent psychiatrist working at Trimiti Clinic, and he is also a faculty at Srimati Kashibai Navle Medical College. Dr. Shukla has worked to prevent child sexual abuse since year 2000. His program of No, Go, Tell in prevention of abuse was featured in Amir Khan's program of Satyamev Jayate and is also adopted by various NGOs and government agencies. He also works with various schools, colleges, family court, and juvenile justice system. In addition to his private practice, he also conducts various parenting workshops. He is the author of the book Basics of Sex, Gender, and Primer for Basics of Sex, Gender, and Sexuality, a primer for parents, counselors, and allies. Please welcome on stage Dr. Shukla.
And keep the lights on, the yellow lights on.
Hi, it's great to be back here again at my alma mater. Spent years sitting in this auditorium as a medical student. So good to be back here after 32 years. All right. So when we talk about 5%, this is the number that we all have been hearing again and again today. And every time I hear that number, I ask myself, so I went to school, I went to college, I did my post-graduation, and I have definitely been a classmate to probably more than 500 people over that much time. Can I identify 25 people from that cohort of 500 who I know belong to the minority gender identification, orientation, and I always draw a blank. And then I ask myself, is it the same today? So it is not, because my daughters already have classmates in their school or colleges who are open, who talk about being of a minority gender orientation or sexual orientation. Why is this difference? And the simple answer to that is that at least in urban centers, the society is changing in a significant way. And this is where your and my role as doctor turns up, as what do we do when one of the 5% is going to come up to us and ask for help. A lot of us don't realize, but actually this is why we became doctors. Right? Because here is somebody who belongs to a minority part of the community, has been persecuted for the longest possible time, is going to face fairly severe negative experiences from all their closed ones the moment they declare their sexuality or their gender to be different than what people expect them to be, and they are trusting you with this information. I think this is a position of privilege. Somebody being vulnerable in front of you, trusting you with the information that can potentially get them in trouble and probably has got them blackmailed multiple times, trusting you with this information is exactly why we become doctors. Every time it is not about diagnosis, because as we know, there is no diagnosis here. We are talking about a variation of normality. In fact, the definition and the variation is now so broad that it's a spectrum where everything is pretty much normal. Just if you're standing at one end of the spectrum, the other end looks almost abnormal to you, or anything other than what is your close by environment looks abnormal to you. That is why it stayed in medical textbooks or even in legal terms as abnormal for the longest period of time, which is also going away now. So what do you do when somebody walks into your clinic and tells you that, doctor, I need help for this? I think the first thing, and I have been in this position very frequently, probably at least once a week over the last 20 years of my practice, because I am known to be a gay-friendly psychiatrist. You know, initially what people said that, oh, he is a gay-friendly psychiatrist, the kind of negativity that my colleagues meant by that label to me has now changed, and I wear it as a badge of honor. That anybody can walk into my clinic and they can talk to me about their orientation or their sexuality to a cis, as my daughter calls me, cis het male. Okay, and the het is not H-A-T-E, it is just H-E-T. Okay, heterosexual, cisgender, heterosexual male, and they can speak with me. That means that I have generated enough amount of trust or at least an image which encourages that kind of trust. So my first job is to thank them for trusting me with that information. But it doesn't come up like that for most doctors. Most of the doctors are not asked this question directly. Because imagine you want to be in the shoe of that 5% first. Be in their shoes. Imagine that you want to talk to somebody because there are lots of questions in your mind. You need help. You trust your family doctor. But are you going to walk into the clinic and ask them a straight question? The answer is absolute no. You are never going to do that. You're going to do a few CTs, confirmatory tests, to know whether the information that you are going to trust your doctor with, A, will be treated with respect, B, you will not be discriminated against, and C, you will not be persecuted. So what will you do? How will you test your doctor? Any ideas? See, we run out of ideas because we don't even know, we have never been in that position. But the commonest idea, which most of the medical students use, exactly. There is always a friend that comes to help. This imaginary friend, a doctor, I have a friend. The moment you hear this word, your antenna should go up because this requires special attention. I have a friend who has this problem. Okay, that is how they are going to start, open the conversation. What should I tell them? That is going to be the next question. And what you say at that point of time makes or breaks the relationship. As a doctor, we are so used to being in that authority position to pass judgments and to tell people what to do with their life, that we don't even realize that we are actually in the spot and we are being assessed. That can this person be trusted? So any kind of question that comes to you about gender and sexuality, a sensible duty of a doctor is to explore it further without passing any judgment. Because if you do not have enough information, I mean, you can be all judgmental as you want, but at least be smart judgmental. Let's at least have all the information before you pass judgments. Okay, so at least start gathering more information. Tell me more about your friend. And one of the key questions is that, why does your friend need this help now? This question, which is a fundamental question in clinical medicine, that why this person, why this symptom, and why the presentation is happening now, is the key question in medicine. In the same way, in normal life, why are you telling me this now is a key question. So asking them that why is this person talking about this issue right now? Again, the word is important. It's not why are they talking about this problem right now? Why are they talking about this issue right now? You may not realize, for you the words may be easy and that is what you are used to. That's your instinct. As a doctor, the words that you use are symptoms, diagnosis, problem, pain, treatment. None of these words are valid in this context at all. Because there are no symptoms, because there is no disease. There is nothing to treat. There is nothing to cure. But the job is the basic job of a doctor, of a healing professional, that is to help with compassion and to prevent pain, to prevent difficulty. So this is where you start exploring that exactly what is the issue here now. What kind of help are you looking for? What do you think will work best for your friend? And all of you who see patients regularly would have the sixth sense developed by the time you have finished your internship, where you know that this is not about the friend, but it's about that person. And it is absolutely okay to tell them with a smiling face that I'm an inclusive doctor. I do not discriminate. So if your friends want to come here and see me, I'm absolutely okay with that. If you want to talk to me about these things, I'm okay with that as well. I'll do my best to help you in this. And for most of the people from that 5% group, this is a very clean green signal. Because believe me, in the day of internet, you would be researched before they come to you. Okay, and we all exude data as we pass along. So there is a good chance that they already know this about you, and that is why they are making that attempt to meet you, but they are doing that one more test before they finally open up. So it is important to ask that question, to tell them that the door is open, and to tell them that there are no barriers. Many of my colleagues now actually put up the rainbow flag somewhere in their clinic in a visible way. So you are giving a very clear signal that this is an inclusive clinic. I think Jyoti is going to talk about it, and you will know more about all of these things. I'm going to talk about only what happens in the clinic room between the doctor and his not so patient who is not a patient. Second thing that people want to know about once they meet a doctor, a friendly doctor, is that, am I okay? Is this okay? Because there are going to be very few people who are absolutely confident, particularly young people, about their own gender identifications, about their own sexuality, about their sexual orientations. Because as Prasad just now told us, that the binary frame breaks down here. Nothing is what it seems. Not just for the observer, but even for the person who experiences it. So they want to know more from you, that is this okay? And this is where one of the simple frameworks that I use is the biological sex, which as doctor, we are very comfortable with assessing. Second is, how do you identify as? What gender do you identify with, or what gender identity do you carry at present? Because even that is fluid. And what is your sexual orientation? Once you know these three things about the person, you have a general idea of the psychological landscape that this person lives in. Be prepared for surprises. Be prepared for answers like, I don't know. Most of us, from the 95%, have no idea how it feels to be in the position where I don't know. What gender do you identify with? I don't know. What stimulates you sexually? I don't know. What kind of fantasies do you use while you are masturbating? Doctor, it varies. I don't know. So the answer that typically irritates most of the doctors, which is I don't know, is that answer that you have to be comfortable with. Because every time you get that answer, you are supposed to say, or what is the most helpful way of acknowledging that answer is that, okay, that's fine. Because it is really fine. Everybody doesn't have to be knowing everything. Then, what kind of help are you looking for? What can I do for you? For a long time, doctors shunned the 5%. Then came a generation, probably my generation or 10 years before that, when everybody started talking about AIDS. And the moment they met somebody from 5%, all they could do is educate them about AIDS. Talk to them about condoms, talk to them about abstinence, talk to them about blood test, and actually give an immediate physical reaction as if you are in presence of a person who is like radiating viruses. Okay, so fortunately for the generation of doctors that are there now, things are a lot better. Okay, but having that welcoming opening there, being ready to live with ambiguity that this person is talking about is the first step. Most of the people will then ask you that I want to come out. This is where the real job starts. Because again, you may not have this experience because most of us live a life where there is nothing to come out about. And we take pride in that. We take pride in saying that I am so transparent, I have lived a life like that, that there is nothing to declare. You know, this is the green customs channel. Everything is clean and open, which essentially means that it's an impoverished life. Nothing unusual has ever happened to you. You have never thought out of the box. You have never tried anything beyond the set pattern. You are railway engines who can only decide the speed, but not the direction. Okay, so here is a person in front of you who has something, a quality in their personality, which has now become the center of gravity for them, and it is actually threatening their existence as they know it. So again, the exploratory question that helps here is, what kind of help are you looking for, or what worries you at this point of time? How do you think this can happen in a better way for you? Now, you all are going to tell me that just few minutes ago, we heard this from Prasad, that if I have to save their life, I have 2 minutes. Even the Bore report, Bore Commission's report, those of you who remember a bit of pharma PSM know that that kind of forms the basis of entire Indian medical system, talked about Indian doctors giving less than 1 minute to their patient in 1945 or 47, whatever it was. Things haven't changed a great deal. We have reached 2 minutes or 5 minutes by now. So it is important to tell people that must be my phone, which I left on. Sorry about that. So it is important to tell people that you will need to make time for this. It is absolutely okay to give them a specific appointment at the beginning of the clinic or at the end of the clinic where you will have more time on hand. Most of the doctors that I meet are quite afraid of telling the patient that, see, I need to talk about this in detail. We'll need a little bit more privacy. This is not the best time in the clinic. Why don't we meet, say, at 8 o'clock or at the end of the clinic or something like that? But make sure that you meet them in the clinic. I hear that again and again from people in the 5% that my doctor said that, okay, let's talk about it, and asked me to come to a coffee shop. Red flag is going to go up there straight away. Okay, that is my doctor trying to exploit me. What is happening here? So stay professional, be in your professional physical zone and clinical zone, but give that extra time. Most of the times, once you have passed all these barriers, people will be interested in knowing, can you help me come out initially with my family? Because most of the people will instinctively know whether their family is phobic or not, hating or not. They would want your help as a trusted family doctor to tame that down. Can you talk to my family? They will even ask you, how will I breach this subject? This is where it starts getting a bit complicated. Because again, what I'm saying here may not be agreeable to a lot of people. My take here is that declare your secrets only when absolutely necessary and to the people who will definitely accept it. The way we do a pre-test counseling for HIV, that kind of counseling needs to be done here. What are the harms of declaring your secret right now? Because unless you actually sit down and help them look at that, what are the advantages of you coming out right now? What do you feel could be the harms or the risks of coming out right now, and helping them understand and ultimately take their decision? Because many times when the parents are clearly homophobic, when the parents are, probably the family for a few years, and that they are going to react adversely, does it really make sense to talk to them right now? One of the biggest difficulties is a lot of people feel that I'm living in sin. I'm giving one impression to my family and I'm living another life. At that time, as a doctor, I see it as my primary responsibility to reduce this cognitive dissonance, to help my patient or client understand that for your own safety, for your own financial security, for reasons that you need to still complete your education and you're still dependent on your parents, if you feel that you don't want to talk to them right now about it, it is okay, it is not a sin. As a reasonable senior voice, what we call as prestige suggestion in psychiatry, it is my job to reduce that guilt. So sit down and talk to them about it. Let them look at the pros and cons of coming out. Maybe there are a few things that they haven't thought about. And typically what things that people miss out while thinking about this is that many times in the family, the decision maker actually lies outside. There is some kaka, mama, uncle, auntie somewhere sitting far away who actually manages the larger family, who's the queen bee or the king bee or whatever the equivalent of that is. And even orientation and availability or openness of that person is equally important, because most of the families will first talk about being ostracized by their larger family. We all are part of those matrices which become bigger and bigger. We are a small subset which is part of another set, and it keeps growing bigger. Helping them look at that entire big picture is important. So I'm not going to go and ramble on about it, because as Jyoti would agree, we could probably have an entire day-long workshop about this with role plays and everything. But the fundamentals, if we stick to the fundamentals in tricky situations, that will usually get out of any difficult situation. So the first thing is a clear message of being open, being non-discriminatory, and being willing to help. Second step is helping the person come out to you first. So moving from my friend to I. And third is coming out to family and helping them understand that this is never a single session job. If this all gets over in a single session, probably something is not happening right here. Because it's a process. It's an educative process and a decision-making process for them and for you as well. After working in the same field for close to 22 years, I can tell you that there are no two people who are exactly the same. Because we are not even going into the details of when people come out, what kind of personality they want to come out as, how much information they want to give. See, if I like drag, and if that is how I participate in the community, do I want to come out with my family with that entire being of mine, or am I going to show them just one slice of that, which is your next level of inquiry? But all of this cannot happen in a single session. So gradually helping them explore the nuances of their existence, that right now you exist in this family and this community with this gender identity, this orientation. When you say that I'm not A and I'm B, exactly what all changes? Are you going to change your Facebook status? Are you going to change your DP? What kind of photographs are you going to post? Which groups are you going to join? What all of that is going to be open or not? You may feel that people would have already thought about this, but many times it doesn't happen. So a compassionate, but at the same time dispassionate person sitting there and helping you look through all of these steps one by one over 3 or 4 sessions is all that is necessary. It is not that you have to take decisions for them, because this is one part in medicine where the risk is entirely carried by the patient or the client. As a doctor, you have zero risk. At the most, you can say that that particular family was relying on me to convert their son or daughter to heterosexuality, and I have failed them, so now they are bad-mouthing me. That very rarely happens, because people and their families don't talk. They just keep quiet about it. So you have zero risk, nothing at stake, except your pride of being a good medical professional and responding to the call for which we really became doctors in the first place. So you can make it as simple, as clear, and as empathic as possible, and all other ways that are more complicated and harmful. So that is where I'm going to stop. Thank you.
Thank you, sir. Our next and final speaker of the day is Dr. Jyoti Shetty. Dr. Shetty is the head of the Department of Psychiatry at Bharti Hospital. She is also the current member of the she is also the current president of the Pune Psychiatric Association. She's an advisor to the IPS Task Force on POCSO and Juvenile Justice Act. And she's a co-chairperson of IPS West Zone UG Education Committee. Dr. Shetty is one of the first to implement the core services model for LGBTQ plus inclusive medical practice at a private medical college hospital. Please invite on stage Dr. Shetty.
Do I get up? PPT. Thank you, everyone. And thank you, Dr. Sandeep Tamani, Dr. Prasad Raj Randekar, for helping us to organize this session. We have been talking about it for a long time now. And I thank Dr. Bhushan for coming at such short notice, actually. This was planned, I think, probably in the past couple of weeks, because it was Dr. Prasad's availability, which was like, at a premium, actually. This is a conversation that we have been having in the department for a long time. As Dr. Kashish just introduced me, what we have, I think when we talk about an LGBTQ clinic, you sort of think that it will be, what is ideally, with a board and lots of, gender neutral toilets and all. Unfortunately, the truth is very far from that. Space, I think, and that I think all Mumbaiites and Puneites will agree, is at a premium here, especially in hospitals and medical college hospitals, so surely. So this is just actually this talk is just to make ourselves familiar with how we can actually make our medical practices more inclusive. And there are just small steps towards the same. So when Dr. Prasad said, I think I have put that, sort of that infogram, that picture on the left. Prasad rightly said that, looking at this hall, it doesn't appear to be, disability friendly either. And that's something I think we have been. In fact, I wish the principal was here. This is something that we have addressed in the past also. When we have colleagues who are specially abled, I think it is very difficult to maneuver and come and attend. Similarly, it is for inclusivity in terms of the LGBTQ community. There was a question someone had asked saying that, why do you have to sit and make it like a separate community? Everyone is part of the whole human population. So why do you want to say that it's a small special community and, you have, so that itself brings about discrimination. But I think here we have to understand is that as of now, there are still a lot of barriers. And I think Bhushan will agree with me, as will Sunita, that, being psychiatrist, mental illness itself is so stigmatized. So mentally ill patients also form a very small stigmatized group. So when we talk about minority communities, it could be religious, it could be sexual, it could be abilities or lack of specially abled communities. They're still in a minority, and then they need to be, sort of, obviously before, it's very easy to say we'll open our arms and welcome them. But as you can see, just as it was pointed out, simple things like, even having a ramp, if it's not available, it shows how the majority community is not even sensitive to the needs. So this is just a step towards that. So the right flag shows a stethoscope prominently on top. I think as healthcare professionals, we need to open our mind spaces to having, we talk about this 5%. Now that varies between studies. It could be anything between 3 to 10%. It varies in which groups of populations you're thinking. For example, in design and art schools, probably the population may be much more of sexual minorities, maybe much less in other groups. So it varies, but 5% is around, about 4.9% or so. So if you look at it, yes, in a class of 100, did I have any sexual minority individual amongst my batchmates? I had, and I knew. And I think we were inclusive as friends anyway. But it's not so for all of us. I think that is one thing that we have to take home. Barring that, I think the person we have been having a long-term association with, Mr. Bindu Madhav Khire, unfortunately we could get, is there a click? Can I change the slide? I think there are a few books that Bhushan has also got, which people are welcome to take because it gives a lot of information. This is a very important book that he has brought out. Mr. Bindu Madhav Khire, I wanted to introduce might talk with his book, the front cover of his book, because a large part of our experience in actually setting up this LGBTQ clinic is because of our association with him. He's an LGBTQ activist, and he's been at the forefront of the Pune Pride marches. He's having one tomorrow. This is a book that has just been released a couple of weeks ago. This is for healthcare professionals. It's very readable. It's extremely in simple language, and it really lays down everything as of now. I mean, it's as current as he puts it, till April 2022. So this book is his education over the years, his activism, and of course, with a lot of interactions with healthcare professionals too. And this is something which is up for sale. If anyone is wishing to buy, we are willing to, just pass on his number. He's self-published it, so it will be through his contact that you can buy it. So when we are talking about why do we need to have an LGBTQ clinic, I'll just go to a little bit of formal, didactics, because what we see is the community has a lot of depression. I won't go into statistics, but it's at least, probably 3/4 of the community probably has experienced depression and anxiety. At least the suicide rates are 3 times more than in the general population. We hear and see a lot of substance use disorders, unsafe sexual practices because they don't have access. They don't feel they have the agency to access healthcare professionals. They feel stigmatized. Sexually transmitted diseases, again, for the same reasons. And of course, their basic unawareness of gender affirmation treatments can probably cause them to have mental health issues. And also, gender affirmation treatments is something that is coming about now. After 377 was repealed, we are having met many more patients with clients with gender dysphoria who do come for treatment and affirmation interventions. So which is why we as health professionals, and this is not only about psychiatrists, endocrinologists, or plastic surgeons. I mean, I would say that, because we have a multidisciplinary team here, it includes a lot more professionals. So where our role lies is in actually reducing ignorance, prejudice, discrimination, and insensitivity. I think Dr. Prasad gave you an understanding of biological sex, gender identity, and gender expression and sexual orientation. So what we need to actually create is the safe zone where all of the three come together and they are protected, and we are allies in protecting it. And I think all of us should be allies without, it should be something across the board. What are the barriers? As I said, because of the stigma, because of their own inhibitions, because of their own misperceptions maybe, or the previous experiences, they don't access healthcare. And of course, health professionals themselves, what we have realized over the past few years, interacting, a lot of us, because of our training being so, we have not actually been sensitized ourselves. So we obviously would be unable to create a system which would be sensitive and which would be inclusive. So it is lack of knowledge in the health professionals too. So when we are talking about tips for an LGBTQ plus friendly clinic or inclusive clinic, as Dr. Bhushan was saying and Dr. Prasad was saying, maybe probably having posters, putting up flags, sort of denoting that you're a LGBTQ friendly doctor who's welcoming people to come and consult. Having a registration form, I think if any, all of us fly to and fro, I think unfortunately when we see the registration for, like when you're entering male or female, there is no third box. We only enter as male and female, right? So then at least these are the forms that you have in your clinic. When you're entering, you can probably increase the boxes. If not, at least have a third empty box, which people can fill as they want, right? We keep it open. Or just keep the space open. You don't even need to specify male, female, right? Examination rooms, which could have privacy, which could have some certain, areas where it could be a safe space. Apart from that, also have assistants. When you have a clinic, you have basically the office assistant, office boy who's outside, probably the receptionist, If it's a hospital, we'll have our staff nurses. We have so many other paramedical, paraclinical help which is available with us. All have to be sensitized about the needs and the requirements of the community. So that is something that is required. So examination involves actually having to educate your whole professionals, all the professionals working with you, and also allowing them, the patients, to have some sort of privacy. Analysis of the investigations is again something. Now we have a lot of patients who probably may be on gender affirmative treatments with hormones. So that is something that has to be assessed. So that has to be with, when you're informing the labs, for example, you would probably have to inform the lab about what treatment they are on too. This is something that's very important as far as restrooms are concerned, making them gender neutral. Probably for lack of space, we all have gender, unisex toilets anyway, but it may not be so in every hospital. So probably having as a gender neutral place, wards. Again, here when we had a discussion with Dr. Bindu Madhav Khire, he had said that why don't you all have a specific ward which is identified for the LGBTQ community, most specifically for the transgender community. I said, I'm sorry, but we have a premium on space, and I think it would be very low down on the priorities for the management to have a separate ward. So we can probably identify a separate room and have the person stay in that room, but it'll be very difficult to have a separate ward. And I think that is true for most hospitals. But it helps to have a safe space, even as far as wards are concerned. Apart from that, sexual harassment is something that is also known. And so you need to have, I think most institutions have ICC, which is the internal complaints committees, following the Vishaka judgment. So then most of the institutions do have it, but that is something that can, happen even in your own independent clinics. So that is again something that you have to be aware of. Education of the care providers. This could start with the receptionist or the inquiry person who's sitting at the entry of the hospital, especially communication skills. Maybe I won't go into, like actually people asking about what gender they identify or what pronouns they use. But if nothing else, they can be polite and respectful. I think that is the minimum that can be done as far as educating the staff is concerned. A multidisciplinary system that should be queer friendly. Now that is something that, maybe among doctors it's a little easier. It becomes a little more difficult when you have the extended healthcare system in terms of all the paramedical professionals that are there. And last but not least, is about being non-judgmental. I think Dr. Bhushan spoke about it. This is something which is why I've kept it in capital letters. We have to be non-judgmental, and that is across, not only about LGBTQ, I think it's about everything. So this is something that we need to keep in mind. This is a hospital. We do have a super specialty hospital now behind. What we have done, coming to the work that we have been doing with Mr. Khire, it started in 2017, where we had our first undergrad lecture by him through the Students' Council on LGBTQ. So it was basically about the initialism, about the minority community. It was more of a experience sharing that he had from his personal, what he has undergone and how he dealt with it. So it was at a very personal level. He also had something similar for our postgraduates, and he's continued to do it, barring the pandemic years, we have tried to have it every year. So what we did after that was we had an MOU, that was a memorandum of understanding with his organization, earlier the Samapatik Trust, now the Bindu Queer Rights Foundation. And what he does is, one is the undergrad and the postgraduate training. So as in when we have, we liaise when having him coming for guest lectures. Apart from that, also having a talk for the paramedical staff, which is currently pending. So I said a collaboration with an NGO. Why an NGO with as with him works is because they have a domain expertise. He's been working in this area for almost, I think, more than 20 years. he understands the needs. So he forms a bridge. So initially it was about his, his confidence also to refer. And then of course it comes from patient to patient, the referral system. So the collaboration works with an NGO. What we decided to have, he has this set of liaison with KEM Hospital Pune and with us. With us, it is basically a core services. So it's basically for treatment, for whatever healthcare treatment that they require. So it could be right from what, it's psychiatric services to any other medical services that are required. So we have created some sort of referral system with the psychiatry department being the, sort of the node which actually coordinates all the referrals. Of course, advertisement is something that is required. We keep having a review of, implementation, how it has worked so far. We have been renewing our MOU since 2019 regularly. We do need to scale up now in terms of, including more healthcare professionals, having focus group discussions with, what we found after actually having over the years that maybe the doctors are becoming sensitized, especially senior consultants, but there are a lot of paraclinical workers, there are paramedical, and there are people who have, keep coming in and moving out. So they keep needing to be educated frequently. So that is something that is, required, as in having focus group discussions with small groups of healthcare workers. So that is something that I think we can do even in our clinics and hospitals. The mental health services is basically assessment, counseling, family education and counseling. We do a lot of work with gender dysphoria, gender incongruence disorders. Intersex, now this is a conversation that we need to have with pediatric surgeons, pediatric endocrinologists, management of all the mental health issues, referrals where necessary, and of course the psychiatrist works as a coordinator. The team, what we have in the MOU, we have actually identified people. So we have the psychiatrists who are there on the team, the psychologist, the endocrinologist who's part of the team, the plastic surgeon, because it helps to have one person, to be identified, or two people at least, because people get lost in the system. People are not aware of their roles also and responsibilities. So it's always better to have them identified. Then we have the pediatric surgery team, as I said, corolateral specialists, dermatology, pulmonary medicine, because a lot of people have, other infections, probably HIV and all, ENT. We have an liaison with the ICTC, and also, with regards to speech therapy. This is not something that we have done yet, but we plan to do in the future. For people who, for example, trans women who need to have voice modulation intervention. While the movement towards inclusion, there has been quite a lot. I think Dr. Prasad and Dr. Bhushan have spoken about it. The Indian Psychiatric Society, that is IPS, had given a position statement in 2016. The then President Dr. Prasad Rao had given it, and of course, it was endorsed and exhorted by Dr. Ajit Bide in 2018. The repeal of 377, Section 377, was on 6th September 2018, and I think after that, it has really helped the community to come out and seek a lot of services. I think it is also about the task forces that the IPS formed, which have helped in, I have to say here that psychiatrists themselves have been pretty judgmental and restrictive in the treatment of LGBTQ community. So then it has been a problem. So the task forces have been having regular seminars. That is one thing which has helped. The NALSA judgment is something that helps the transgender community. Of course, the Transgender Act in 2019 has had everything that has been laid out pretty clearly. The MHCA said 2017 is the Mental Health Care Act, which also prohibits discrimination on sexual orientation. Then coming to BIN Medical College, I think the major improvement of change has been in the curriculum, which is something that I think we need. It was very belated, but it has happened. What we have is a competency-based medical education, which started in 2019. The first batch came in 2019. And what they have done is the NMC, the National Medical Council, has actually put up committees for recommendations. So it could be about forensic medical textbooks. In fact, the committee was formed following the Madras High Court asking the NMC in 2021. So the committee was formed, one of which was a professor of psychiatry in NIMHANS, Dr. Prabha Chandra. So it was about recommendations for changes in the forensic medicine textbooks. And second was about conversion therapy for LGBTQ community. So, conversion therapy practiced by psychiatrists. So now it is punishable by law. So that is what the NMC has said since February. I mean, that was a response to the High Court in February 2022. So it can, our professional degrees could be obviously at risk if we practice this and we are found to be practicing conversion therapy openly. So that is the change that has come through regulatory bodies, which is very important. So the CBME is one, and of course the NMC position on conversion therapy. And this was, of course, thanks to the Madras High Court actually last year. Apart from that, what we also have is, this is something that is recent, that's Sangat, which is again an NGO, with a couple of other individuals like Dr. Satyendra Singh. They have been trying to develop trans care competencies. So it's about developing competencies to deal with transgender individuals, formulate some sort of plan. So the training happens at the undergraduate level and then continues to the postgraduate level. Okay, so it is not only about about addressing them or communications with them, but then it's also about how to take care of them. Okay, so this obviously improves the accessibility, it improves the agency that the LGBT community can have in accessing care. So these are the changes that have happened. And as I said, the last two are very important because the last one is from a regulatory body. And I think we never understand anything unless we are punished. So I think that's something that really helps us. So these are all the areas of work. I think Dr. Prasad just touched on, things like heteronormative factors and, some critics of that, and some people have differences of opinion about whether, marriage is heteronormative and is it something that needs to be followed. But yes, there are lots of people who are activists who are proposing that marriage is something that, of course, it is allowed under the Special Marriages Act, but they want much more coherent, more clear guidelines, probably a marriage act specifically for the community. Adoption is one area. Surrogacy is another area. At present, it's obviously not allowed. Sexual harassment should be gender neutral. I think the POSH Act, as everyone knows, is something that's very specific for women, but it should be something that should be gender neutral. There could be a lot of trans people, LGBTQ people who are working, and they also can be harassed, and there should be a mode for them to seek redressal. Barring that, I think most government institutions would like to reduce the trafficking and begging that we treat, especially from the transgender community, the specific community, and they try to see that there's much more inclusion in the job fields. Barring that, I think there have been job reservations in small pockets. One is, I think, in Kerala, where it was about, the metro rail, where transgenders were probably employed. But I think a lot more needs to be done in that area. So these are something, why I put it here is because we are all part of a community. I mean, we're all part of society. I think if we work as allies, this is something that we can add our voice to also. So it's not only about me being a psychiatrist and sitting in my room and just treating patients who come to me. It's also going forward, as Dr. Bhushan said, and being active in actually promoting something that could be, LGBTQ inclusive. So this was, this was an honor actually to be invited to be Grand Marshal at the 2019 Pride Walk by the Bindu Madhav Khire's team. And this is my contact details. Thank you very much for a patient listening.
Thank you, ma'am. For the final event of the day, I would like to invite Dr. Prasad to please invite the panel.
So more than that, we have discussion, which is about so please again come closer to us. Dr. Kanchan is here. May I request Dr. Kanchan to please come on stage. Dr. Kanchan Gaur is joining us as a panelist. She is a primary care physician and local consultant who's working with Mitra Clinic. It's a center for transgender health in Pune, and it is implemented by YRG Care. She previously worked as a medical officer in Avahan, which is working for HIV and AIDS prevention in India.
Yeah.
Yes, sir.
So the idea. So the idea of the panel was that we can bring in some of the discussions which has not come through. I mean, as Dr. Shetty was saying and Dr. Bhushan was saying, that we could spend the whole day talking about various aspects of this. I wanted to bring in Dr. Kanchan as an expert because she's been working with the community for a long time. And like while Dr. Bhushan Shukla and Dr. Jyoti has a wide experience on working on the mental health part of it and setting up the clinic, I want to bring in Dr. Kanchan, you as an expert as to what has been your your experience on working with the community and the physicians, and what are the barriers that the LGBT community faces in accessing good quality healthcare?
Hello. So I'm currently working at the Mitra Clinic, which is a Center for Transgender Healthcare in Pune. It's a part of Project Accelerate. So it's funded, it's a charity project. So it's a funded clinic. Can you hear me?
Yeah, thank you so much.
Okay. So I've been working with the LGBT population primarily in the context of the HIV/AIDS interventions that were being run around in India. So we are talking about Project Avahan here. And as was mentioned earlier, we only looked at MSM populations in the context of HIV/AIDS and STIs. That's the discussion that we used to have. And essentially, it was just about, are you having safer sex? Are you having, are you using condoms? Do you have any STIs? We need to get a, have you had an internal or an external genital examination? And that was the scope of the discussion as doctors. And as a technical officer, I used to actually go out and talk to private practitioners in Maharashtra, not later also in Madhya Pradesh, about the need to treat the MSM population with a non-judgmental attitude so that they come into the clinic for their STI checks and their HIV tests. So the intention at that point was always basically about ensuring that this group is a high-risk group, transgenders and MSMs, and they need to get vetted regularly for their STI test. This was a very limited conversation. And from there, I think for the past 15 years, I've now come to a point where I'm actually able to sit in a clinic that provides specialized transgender healthcare. My experience with the community is that they would go to a quack who talks to them kindly, who talks to them with a non-judgmental attitude, accepts their problems or whatever, accepts their identity. For transgenders, especially cross-dressing transgender population, this is a huge issue. We might not realize it as healthcare professionals, but we might say, yes, I talked with him as I talked with any other patient, but there's so many cues. There are non-verbal cues, there's body language, there's an intrinsic discomfort that these people are very, very sensitive and they pick up on it and they prefer not to come back. So we've actually seen clients who have actually come at the end stages, even HIV/AIDS for that matter, because they hesitated approaching any qualified doctor, any allopathic doctor, क्योंकि वो लोग तो हमारे तो सुनते नहीं है, हमको क्लिनिक में बिठाते नहीं है. They are concerned and they are told not to sit in the OPD room. So this is, I think, for me, I mean, from what I have, my interactions, this has been the biggest barrier to access, the fact that they don't really feel comfortable in clinical hospital, I mean, in our clinics. This is number one. Number two is often when a transgender, when a hijra walks into your clinic, you are so intimidated somehow by that entire presence and getup that you just, or they tell me that they just feel like they are being shooed away. If they have a problem which requires a examination, many doctors do not even bother to go to that level. ऊपर से पर्चे लिख के देते हैं. And so, basically they just get treatment, but it's not even good treatment and they can see it. They don't experience relief. Which is why I feel, again, they prefer to go to quacks, or they prefer going to places, or even asking the chemists for that matter. A lot of these people are taking so many OTC drugs, even hormone medications, gender affirming hormone medications are being taken over the counter because they just don't feel comfortable or confident approaching healthcare practitioners. So for me, I think that has been a learning experience.
And I want to share my experience here of the things that you brought in. I mean, as an oncologist, I conducted a cancer awareness camp with one of the NGOs, LGBT NGOs in Mumbai. And as a part of that, we did examinations. And when I examined a trans man who had not had top surgery, so that individual was sitting and we were chatting and everything happened, and then they went inside and they undressed. And when I entered the room, I went sort of numb for a second because it was the first time ever in my life I had seen a trans man who had not had top surgery. And it came as a shock to me also when I had to do the breast examination. I literally had to take a second to sort of, gather, because it is something that we were never taught. It is something that you have never seen. So every time that you see something different for the first time, it becomes so much more difficult. But there is learning, and seminars like this and far more detailed workshops that we conduct, I think will pave in the way for these things. I want to comment on the point that you spoke about access and people going to quacks. When I start generally my these seminars, I tell the doctors that please understand that understanding about the LGBT community is of course a good thing to do, because that's the right thing to do. But it's also a very right thing for your bank balance, because you have one LGBT community member coming to you, and if that person is happy, then that person is going to refer you a lot of patients.
Yes.
I mean, I know my dermatologist. I met him like 10 years ago, and God knows how many people I have sent to him. Because he is super, super friendly with LGBT community. And that's because there are so many less people who are like that. So that's the problem. But coming to psychiatry part of it, Dr. Jyoti and Dr. Bhushan, what are the challenges that you have sort of noticed in the clinic from the mental health point of view? We really didn't speak today about the mental health issues which are faced by the LGBT community, which arise from the ostracization from the society. So do you have any things to share on that?
Yeah, I didn't actually spend much time, but as I said, as far as depression is concerned, we do see patients with depression. Suicide is, as I said earlier, is 3 times more, and especially more so in the transgender community. I think there is even a judgmental, negative attitudes in the LGBTQ community against transgenders also. So the non-binary population probably has even more mental health issues compared to the whole rubric of the LGBTQ community, or gays and lesbians, for example. But we see much more depression, we see much more anxiety, there's much more substance use disorders. So that is another thing. So dealing with that, as I
Self-harm.
said,
Lot of self-harming. behaviors.
self-harming is something that is very known.
Self-harming.
So even if they don't complete, they don't die by suicide, there will be a lot of self-harming because of the distress that they face. Barring that, it's also important to sort of what happens is that, as Dr. Kanchan was saying, healthcare access for anything. It could be something very simple. It's not that they don't get fever or they don't get any other infection. But even access for that, going to a regular physician, a family physician, is something that they very much feel inhibited about. So that itself becomes a problem. So then even other health issues are ignored. Because of that, that again obviously has a sort of repercussion on their mental wellness. Barring that, I think mental illness or even psychiatric disorders, it's not only about their gender identity or sexual orientation. It's what we talk about is minority stress. I think we didn't discuss that at length here, but minority stress is a model where it is discussed about the internal stressors that are there, the external stressors that they feel. So the internal stressors are, it's about even facing up to their their identity, their sexual orientation, their initial confusion, and then coming to accept it, and the distress during that way. External is what they face in society, as Dr. Prasad was saying earlier. So those are the external stresses, and it is not only about the identity or the orientation, it's about just normally just going to work, just being able to travel in a public transport like other people and not be harassed or not be discriminated against. That itself also causes a lot of mental health issues. So these are minor things that happen, which just keeps building up, which is when they come to us. I think coming to a psychiatrist is, at the end of having gone through a lot. So, coming for treatment, if they are aware of treatment, they will come. Even coming for treatment, they may be having inhibitions about whether they can access a psychiatrist in a public hospital, whether they can go to someone. And we have had a lot of negative feedback about private psychiatrists who probably have been discriminatory themselves. So this is something that, this is why a conversation has to be started. So it's about healthcare professionals in general who have to become sensitive to this issue. So depression, anxiety, substance use, suicide forms the major part. Apart from that, I think just because we have been working so much in gender dysphoria, I think it's about ruling out severe mental illness also before we make a diagnosis of gender dysphoria is something that I think psychiatrists need to be trained about also. So those are my inputs for that.
I may work mainly with young children, people up to 18 years of age. And one big change that has happened over the last 10 years is access to internet. Something that we did not see before that. Now, the moment you have a question in your mind, the older generation used to Google it, the newer generation YouTubes it. So you want to hear somebody speaking about it, you want to see films about it, you want to see more information about it and all of that. So you have very young children who are now more acutely aware about them being different or even exploring. This is something that practically wasn't there just 10 years ago. So children are becoming aware of them being different much earlier on. And as we know, the early on they realize this, more difficult it gets for them. Because their cognitive apparatus is not very well developed at that point of time. Everybody is looking at them as almost asexual beings when they are becoming aware. And we know from research that the majority population, the heterosexuals, can afford to ignore their sexuality for a lot longer. The traditional advice that is की हे करायचं तुमचं वय नाहीये आता तुम्ही अभ्यासावर फोकस करा नावाची गोष्ट if you are a cisgendered heterosexual person is much easier to accept or even understand or go along with. But when sexuality is the core of your identity and you know that there is something different here that other people don't understand, it becomes a very difficult battle. And this is the pattern that I see unfolding in my clinic again and again. Children presenting with relationship issues, with irritability, with inability to focus, a lot of self-harm. And when you explore and when they actually learn to trust you over a few sessions, that is when these things surface. So mental health getting affected because of awareness of being of minority sexuality is literally an avalanche that we are facing in the clinic, and it's not getting any better because parents always grow up much more slowly than children, and that's always the difficulty. You know, I hear this from a lot of parents. I know my baby was so sweet. You know, doctor. The only problem with children is that they grow up very quickly, and children say, "Doc, the only problem with parents is that they just don't grow up at all." So that kind of tussle, that battle unfolding in clinic is something that we see more and more commonly now.
I would also like to add to this that we are sitting here in Pune, which is a metro city. People have access to smartphones. They're very clued into Instagram and all the other social media channels. Let's not forget there's a very large chunk of people who live in rural Maharashtra. And I see these people who come to the clinic. They are so confused. When it comes to mental health, first of all, they are not even able to differentiate whether they are transgender, cisgender, or whether they are homosexuals or not. And often it is the first discussion that they will have with a mental health professional such as Dr. Jyoti or even Bindu Madhav or a psychiatrist or a counselor or even a receptionist at our clinic, that they figure out that being homosexual and transgender are two different things. So there is this essential confusion, which also as healthcare professionals, which is why I feel it's so important for family physicians and primary care physicians to have a thorough understanding. You might be the first person of contact for such people, for such confused youth in rural Maharashtra, for whom, you could be that person who explains to them that, hey, you're not transgender. Teko sab log, chhappa bol rahe, to iska matlab ye nahi hai ki tum transgender ho, you're gay. And explain the difference. And therefore, before we reach a specialist, it's often the family physician who has that privilege and who has that opportunity to reach out to confused young boy or young girl and make things clear and guide them to the right people. But for that, we need to be non-judgmental ourselves. And in fact, one of the most important things that you can do to make your clinic LGBTQ friendly is, say, for example, a trans person walks in and calls himself, I mean, you see that the person is a man maybe, but he's dressed up as a woman, and he calls himself, I don't know, Zara. You call the person Zara, you refer the person according to their identified gender, and that itself is something that immediately sets them at ease. So yeah, that's what I want to say.
Now we've spoke a lot about transgenders and we spoke about a lot about gay men, but patriarchy is in our bone marrow, right, in Indian society. I remember I was talking to a lesbian friend of mine, and she was telling me, Prasad, there's no question of my sexuality being discussed as lesbian because women are not supposed to have any sexuality until that magical day when they get married. And then their sexuality is linked to what their husband wants to do with them. So what has been your experience as a community worker when it comes to trans men who are women who are shifting, or lesbian women if you are coming to, because probably, I mean, this again is a controversial thing to say, that being a cisgender gay man is far easier than being a lesbian or a trans man.
Yes.
So what has been your experience in the community?
So in the 10 years that I practiced as that I was working with the Avahan project, I just knew one person, one not officially transition per se, she didn't even identify, but one could make out, and she was very comfortable referring to herself as the fact that she was a man, but we all knew. So that was it. They were invisible. The first time that I saw them was at a Pride March that was organized, I think, in 2013, again by Bindu Madhav Khire. And that picture just reminded me, I was wearing a really nice, colorful red cap, and I went there to support as an ally. And that picture came in the midday mirror. And my whole family in Nasik and Pune exploded. They're like, what are you doing in a pride march? Are you lesbian? And I was married at that point. And it was such a controversy, everybody had 1,000 questions, and I had to practically tell people, explain to them that I was just there as somebody to support. And not everybody who is at the Pride rally is, LGBTQI plus. So that picture really brought back memories. So that Pride rally was the first time that I actually saw the lesbian community out and loud. Coming back now, I do see trans men coming to the clinic, and I would have to say this, they are much more, I find them sorted. They've gone through the whole process very systematically. They studied about the gender dysphoria. Most all of them I've met have a very clear idea. They're not confused. They've gone through enough counseling, and they're very happy to be making that transition. Of course, they're facing issues at home, and these issues are more legal sometimes more than anything else. It's about property issues. It's about families throwing them out because the brother says कि यार तू आदमी बन गया, इसका मतलब ये मत समझ के तेरे को प्रॉपर्टी में इक्वल हिस्सा मिलने वाला है. Those issues. And so I also find that, it is very important to have a referral system where we can provide them good legal resources as well to help them with these issues that happen with gender transition. The community, I find, is becoming, is coalescing together, is becoming more, how do I say, asking for a seat at the table, which is something that I think trans women have been quite vociferously asking for the past 15 years. And you see that in national events and in team meetings that, the trans women and the Hijra community, for example, they are much more assertive. I also see that now happening in trans women as well, that they are trans men as well, that they are speaking up for what they're going through and what they expect, the kind of help that they expect. It's very slow, but it's a definite change from the past 10, 15 years.
There is another stream that is happening along with it. And I think that goes a lot with our culture and what we are as society. What I see again and again is families, quite a few families, being very comfortable with trans men.
Yes.
Because they know for sure that this woman is not going to get married. She's not leaving home. In fact, can be financially exploited. Because now all her earnings, his earnings, are now family's earnings. Let's take a claim on that. And in a very classic bargain, we accept you as you are, provided you are completely subservient to us now financially. And take the responsibility of parents. Brothers are more than happy to move out with their wives and leave elderly parents to trans men. And it is entirely their finance. क्योंकि तुझे बाकी तो कुछ है नहीं, तो बाकी क्या responsibility? Toby, why don't you look after your parents? So this is something that we see happening in society. In younger age group, I come across, even for the first time when I saw it about 10, 15 years ago, I was shocked, but not anymore because this happens again and again. Parents are okay, their daughter declaring, adolescent daughter declaring that she's lesbian. Why? Because now we don't have to worry about her boyfriends. It's not going to be a problem, right? Her girlfriend can come over, they can have sleepovers, they can be together all the time. And it's not a problem for us because it is not an issue. Nobody's going to notice, nobody's going to see anything. If she had a boyfriend, we would have trouble with that. So society, family can have their own bizarre priorities and can find solace in God knows what. So I wouldn't say that it is that easy, but again, how that particular family looks at that person as a resource or a problem or a solace or what, just tells us how rotten we can be as a society, that's all.
Or selfish.
I think selfish is the right word. And, I came out to my mother in 2004, or rather my mother forced me to come out in 2004. I finished my MD, now it's time to get married, and why do you not want to get married and all that circle. And then she sort of forced me, I came out. And then it took me 14 years to mend my relationship with my mother. 15 years. Now we're good. But the reason it happened is that I realized that she's not actually worried about me being gay. My dreams got shattered. And then you are a problem in my life because I wanted this and you're not giving me that. And it took me a long time to reconcile with that.
With that
And
guilt.
when your primary relationship in your life, your mother, says that, you're not good enough because you didn't do what I wanted you to do, it's really difficult to, come around that. But such is life. So, audience, now, not any questions. What are your questions?
Even comments, I mean,
Questions and comments.
anyone comments, I think my residents are there. So, yeah.
Okay, pass it.
Here.
I just wanted to tell you that this is a great orientation program. This is only a handful of us who have got oriented. There's a lot of people who just do not know, not only the layperson but the medical fraternity. They just do not know anything about all this. I am from community medicine. So I want you people to really orient the medical officers, who are working in the 30,000 population. There may be so many, as you were saying, so many of LGBT people there. They should be able to identify these people and work for them. So medical officers should be oriented. Secondly, I would say that in the medical education part, internship is the place, where at least 2 sessions, such type of 2 sessions, and there is a lot of time. 15 days training program is there for these interns, Out of that 2 sessions, you can definitely take and train them and orient them of what all you have told us. And I'm so happy that this thing has traveled from the stage when I was studying forensic medicine. All these things were under sexual perversions, That is what I have learned.
Yes.
So, and it has come in open now. So it's a lot of progress that we are doing, but not in this closed room. Every one of us or every one of people should know, at least those who are educated and can understand, should know all this, So how you can plan and how this can be done is all up to you, but people are doing a great work, and it should be extended and scaled to whatever level, to colleges. And as you said, it started from HIV/AIDS. The counseling has already started. Pre-test counseling, post-test counseling, the process of counseling has been taught everywhere, and all medical fraternity knows all this. So taking from there, you can include all this and make it inclusive, as you're saying. So it's really sort of open this thing for me. I have learned a lot from this 2 hours.
Thank you, ma'am. And just for your information and for everyone, it's being live streamed on YouTube. So it's accessible.
Okay.
So in fact, I think we posted the
But
link
how many
also.
of people are going to actually
Yeah,
open
but then
and
the thing is,
learn?
as you said rightly, NMC, unless you have regulatory bodies changing the curriculum and forcing everything
I
down
know,
their
but
throat, it doesn't
you have
happen.
1 or 2 hours in internship programs
Yes.
from psychiatry department.
We have been doing
There-
it anyway. We have been doing it at the undergrad level. In fact, there's an undergrad student who is also doing a survey actually. She's doing a study on that. So the thing is, it has to obviously percolate to all colleges, So all medical colleges have to come up
Through
in terms of, so
Through
then,
MUHS.
yes, that is something that is required. But as I said, I think we need regulatory bodies to sit on top of us and force it also. So, so one good aspect is just like disability competencies, something that is being taught. LGBTQ competencies and trans care competencies are also something that will come into the curriculum.
Yes.
So that
we're
is
working on
something
it,
that
actually.
will bring about whatever change that we expect and we hope for. So definitely there's going to be changes in the curriculum, which is required. Thank you very much for your
Couple of questions. Dr. Bhushan talked about coming out to doctors. Now, I am practicing for so many years, as a physician or a geriatrician, but not even a single person has opened out to me. So, do they prefer to sort of open to or come out to psychiatrists or any specific, specialty doctors? Because this is when I listen to you, I thought not even a single person has come out to me. When I see so many, all of us see so many patients per day. So do you see, have you noticed that they open out more to psychiatrists or maybe to family physicians, or what is your experience?
Yeah, I think psychiatrists are definitely in a lot better position for that, because not only our consultations last a lot longer, you are allowed to speak about things other than your physical problems to a psychiatrist. And that gives a big open door to talk about other things. Time is the second factor. Third is actually privacy of the consultation. Most of the psychiatrists are quite acutely aware of how we physically arrange our clinics. Can the person sitting outside hear what is going on inside? What kind of things that we do? For example, in my own clinic, there are always windows which are open, so the white noise of traffic drowns out whatever is coming in from my clinic. And every time I do a decor or change the decor or something like that, I make sure that my room is reasonably soundproof. Most of the times, particularly in general practitioners clinics, there you can actually see what is going on inside. You can very well hear what is going on inside. So that fear is always there. The receptionist or the compounder in the older days has a lot of access. Note keeping is pretty much open. So if I am from one of the 5%, I'm going to feel very vulnerable there. I'm not going to trust that position. And as it happens now, most of the family practitioners are actually of an older generation. A few years ago, I did this survey, and there is not even a single MBBS general practitioner practicing in Pune who's younger than 45 years of age. And there is a lot of ageism there. Well, but you are in community, you are not in private practice.
So also in private practice.
So the ageism is there, that this person belongs to my father's generation or grandfather's generation. They are not going to get this. I'm not going to talk. So there are lots of barriers there. That's why family physicians need to make extraordinary efforts to send that message out clearly that yes, we are open. We can talk about this. Putting up a flag or a poster in your waiting room would be just a starting point of that.
Maybe if we see somebody coming to me as a physician, the natural reaction would be to refer him to the psychiatrist, which now I may probably change. I'm sensitized to that.
Also, keep in mind, most of the time, if they want to talk about issues like this, they will go to a doctor. Pune ka banda PCMC mein jaake kisi doctor se baat karega, because they're so paranoid about, this thing getting out. So they'll prefer to consult an unknown doctor as far as possible from their place of residence.
We'll register under a different
This is
name
especially
altogether.
true for smaller cities and towns. I mean, we have patients who come, like who are from the middle socio-economic group or low socio-economic group. They come from very small towns. One is because of this, that, her factor that everyone knows everyone in that small community, and they are known, so then, and of course, family physicians may not be sensitive anyway, but then the family physician will probably know your whole family also. So then they obviously will not be comfortable talking to anyone there in their own town or their, their small cities. So they come to a bigger town because there is anonymity here. That is one aspect that they also prefer. And that is also another thing why we see much more of an LGBTQ community in bigger cities. I think that anonymity that is provided also helps them to assimilate, whether it is for work. I mean, we see a lot of people who have moved here. So it is not only about the discrimination or, probably the stigma or probably the negative reactions at home. It's also the fact that here they can be part of a large system where they are not identified. So, they will probably move out and stay with probably their partners without anyone finding out or being any wiser. So, the families are way back home, they probably don't even visit them.
I think every physician should have a counseling room separated in the clinic.
So gynecologists, psychiatrists, and endocrinologists are the ones who usually
Dermatologists.
I'm a surgeon practicing in PJs, so some hospital. So I have attended many surgical emergencies of specifically transgenders because they are visibly like maybe they don't reveal. Maybe many lesbians have come to me for examination of their private parts or something. They felt more comfortable with people not to take surgeries. But problem comes with resistance of residents when they're asked to examine their private parts, specifically with transgender. Many procedures have to be done, like catheterization or examining of sexual organs. So I think that has to be taught somewhere.
Yes.
If they come with the number which comes to us is very less. Maybe in a year we face only 3 or 4 transgenders who come with but there is resistance in society. Like when we usually there are trans women who come to us more, so we admit them in female wards. Problem is not admitting them. The problem comes with the patients around them. It's a general ward. So they like even if I operate them and need them to stay here for 4-5 days or 6 days, they're not ready to do it because whatever resistance or the looks or the behavior they face from the surrounding patients, actually that matters more. So I don't think we will have solutions so easily at present now. It may take time. Like we need to counsel the society more. Like doing counseling of this patient person is important, but actually the society, the family, they have to be counseled more. Even the healthcare providers, they have to be trained more. Like to be non-judgmental or non-discriminating. That is what I think. Just wanted to share my experience.
Yeah.
So while we spoke about privacy in the clinic, we also have to be very cognizant about confidentiality. I met a doctor 4 days ago. He identifies as trans man, and when he first met his psychiatrist, medical college psychiatrist, the first thing that psychiatrist did is call his parents because he knew them and saying you have to put some sense in your child's brain. This is all wrong. This is all rubbish. And then that became so traumatic for that individual. And fortunately they came out of it and transitioned. But it was very difficult because they went to the psychiatrist for help, and that doctor broke their confidentiality, and that created problems.
So this may sound a little bit harsh. There is a saying in science that science progresses from female to female. People who are holding those dogmas and authority positions, unless they die, science can't move on. For medicine, it progresses one law and one lawsuit after another. So unless some big ticket compensation is awarded to a patient for breach of confidentiality by their doctor, I don't think doctors are going to take cognizance of that. Because doctors, unfortunately, are the most conformist part of society. You do not see society moving ahead because of doctors. It's quite the contrary. Doctors are forced to evolve, otherwise they will perish or they will be severely punished. We have seen that happening in mental health. That entire community needed to be dragged out of 18th century, kicking and screaming with a law and opposing that. And that is what we doctors are. Let's be open about it, that we are not the most progressive lot of the society. So unless we shape ourselves up, we will be slapped with massive fines and laws which we will forever moan on our private doctors' WhatsApp groups as how society is being very unfair to doctors.
We have a question there.
Thank you. My name is Anuja. I come from PRE Foundation, which is Transgender Welfare Equity Empowerment Trust. So I've been working with the transgender community for about 1 year, and I'm working with them as a mental health counselor. So first of all, I would like to say that today's session was really amazing, and it's a great initiative for creating awareness even among the medical professionals. So what I wanted to share my experience and thoughts is that there are many transgender, as we were talking about the latest generation, the age gap group of say 18 to 25 of transgenders as of today. They are very keen on studying further, but because of a lot of harassment, bullying that happens at school level, where most of them are school dropouts and not even 10. But now that I'm working with them for the past 1 year, they are really eager to study further. And I have just one thought in my mind that many of them are very keen to work in hospitals. They are ready to do patient care, they are ready to take care of patients, and they may be 10th pass or 12th pass, or if not, they are willing to give the exam And if there's any way in which we can train them, as like a ward boy or a ward woman, the ayas in the hospitals, I think that also will be a great initiative for inclusivity and diversity and helping the general population as well.
I just have to answer that because when I spoke about the two models, in terms of Bindu Madhav's work in this area, for us it was court services largely, but I think he was trying to do this with KM Hospital Pune. So I would suggest probably you can speak to him. In fact, I think it also depends on management because we are a medical college hospital, so it's a private hospital.
So my name is Ritu Ahe, and I'm a non-managing translator. And Reformation is doing a shelter home. Central government is supporting us for that. So we have a shelter home for youth families between 18 to 60 years of age. So basically, she is our mental health counselor there, and every day, every single day, I have one or the other person coming to me saying that, ma'am, I have much depression about my gender identity. But I am totally lost. You know, then I have to talk to her. I just take her attention towards me कि नहीं मेरे साथ बैठो मुझे बताओ मेरे बच्चों को क्या आंसर है. I am also बच्चा again I'm just 26 years old and but I work for all these people from 18 to now we have 25 years of age people coming to our shelter and every single day I have to face this mental health sessions with everybody because she couldn't afford to come every day because she has practicing in some institutes as well. So trans women का तो हम बोल सकते हैं because I can solve their problems. But when it comes to trans men, they always say कि हमको घर पे यही बोला था कि मुझे तो कुछ चाहिए नहीं थी ऐसे लड़की because Indian society का वो thinking बड़ा है कि लड़की हो गई तो उसको दुर्गा दो वो सारी चीजें होती रहती है and trust me a very small town वहाँ से एक trans man आया था उसकी हालत बहुत खराब थी and वो चलो physically तो हो गया settle but till now he is not mentally prepared कि वो कैसे करें.
No, but then, as I said, why we have been actually talking about liaising with NGOs for this reason. I think as far as Mitra Clinic is concerned, we have liaison with them in an MOU with them. We have an MOU with Bindu Madhav Kiresh Foundation also. It's for this reason. I mean, we are welcome to, we can always talk about it later.
Yeah,
Probably now is not the thing, but then you can always contact me at any time.
Sure.
Because yes, I think as you said rightly, finding the right people at the right place and being accessible is also a problem. So I think these sort of sessions obviously hopefully will help in building those liaisons.
Yeah, really sure.
Thank you.
One last question from the residents who are clearly majority in this room. So we want a question from the majority. You don't have any questions, so you don't want to ask them.
A lot of questions.
So, how was it sharing your own experience? How did you come to terms with you want to share your own journey with the world? How did you come to terms with it?
So, every queer individual has their own story, and there are very few stories which are very positive stories. When we speak about coming out is a process by which the individual tells people around them about either their gender identity, sexual orientation, or other things. And the reason why we need to come out is because heteronormativity. Like people assume that I'm a man, so I'll marry a woman. So I have to come out and tell them, you know what, actually that's not it. But the reason why I had to hide into a closet for me to come out was because of the fear that the society will ostracize me, society will look down upon me. So that's why I was hiding. And then I came out. Now, I came out to my mother in 2004, as I mentioned. And before that, I had to hide myself, right? I had to hide myself from my own parents, from my own friends, and things like that. And it is so difficult because you're continuously spending a lot of energy in creating stories. So I used to suffer from severe migraine, and severe migraine as in I would lie in bed 2 days, vomiting my guts out, and I would feel as if I'm just going to die. Everything stopped after 2004. I have never had a migraine after that, never. And I have taken like, I had gone right up to beta blockers. Paracetamol and migraine was like peppermint. So those sorts of things happen. The first coming out I actually did change my life because I was 16, I had just finished my 12th exam. I was really close to a friend of mine who still continues to be a close friend, he's a cardiologist in US now. And I felt that I was literally cheating him because I was with him all the time. We were traveling together, in college together. But this part of my life, I had not told him. So after our exams, I took him out, we sat down and I said, I want to tell you something. And I said, I'm gay. And there was silence for a few seconds, and those few seconds really freaked me out. And then he said, yeah, okay. So I got very confused. I said, did you understand what I just said? So he said, yes, I understand you're gay. And what? I mean, what do you want me to do now? So I said, I'm not sure you understand. He said, I understand, but nothing changes. And that completely unconditional acceptance of somebody whom I dearly love really changed my life. That is why I'm able to be on this stage, because for the first time I felt accepted by somebody unconditionally. So as an ally, I think that is our role. That if somebody comes out to you, don't, I hear people say, you know what, you're gay, that's fine, just don't behave like it. When you go out, just behave natural or normal. Yeah, that is not an ally. That is a homophobe. When you accept somebody for who they are, you enrich your life and you enrich their life. And that is the role of an ally. And that is what we hope that we build through these programs. So on that note, I think I would invite Dr. Sandeep to come over here, who has been the mastermind of this program and getting us all together to just say the last word. Yeah, sorry. Yeah.
So very good afternoon to everyone. Thank you for this wonderful session. And I just had a very basic doubt to ask. So in the very first slide that Dr. Prashant showed us, it was how the majority and minority battle is going on. And I'm very sure like the medical professionals and the layman, somewhere this battle is still, you are experiencing it, you are having a lot of challenges. So now as a layman, I want to ask that somewhere we all are stuck between sympathy and empathy. And the basic purpose is how we, develop this feeling of compassion and do something about it. So as a layman, how can, we contribute in a very small way? Like most of us, we at Signals, as we said, we experience this community of hijras coming to us, and all we do is just show a bit of sympathy or empathy. That's it. But how can we, develop or contribute a little more in this thing?
So when we talk about sympathy, empathy, compassion is action oriented, right? You actually physically do something, or you stop doing something, or so when you talk about compassion towards the LGBT community, I actually invite you to be compassionate irrespective to everyone. Compassion is, I spoke about compassion in LGBT context today because that is the context of the day. But as a physician or as a layperson, it is our responsibility, and I feel it is the right thing to do, to be compassionate towards everyone. And those barriers that I mentioned to compassion are applicable to all of us. I'm likely to feel more compassionate about somebody who's like me. And then you have to really identify the actions that you may take. So, for example, the action could be paying 10 rupees to a Hijra who's on the street begging, or reaching out to Bindu Madhav Khare and making a donation to his trust, where he will actually work with them to change their lives. So, compassion is all about not just saying, oh, this is so sorry, or saying, oh my God, I feel so pained by their pain. What are you doing about it? You know, I get a lot of criticism from everywhere. You know, heterosexual community, homosexual community, LGBT community. I run a group of older gay men called teenagers. I get hate for that, saying, but that teenagers is only for gay men. Why are lesbians not included? Why trans persons are not included? My answer is very simple. I am very, very happy to contribute to the group that you are starting. Let's start that group. You start the group, I'll support. Don't criticize, do something. So you move into action, do something. And that something could be very small or it could be very large. Doesn't matter. I believe in small acts of kindness. If you do small acts of kindness every day, the world will be a different place. Would you love something? Oh, sorry,
Yeah. I think what you also meant to say, correct me if I'm wrong, is how do we be more inclusive? What can we do to bring out, or to associate with them or to work with them together? And I think what a really good thing is there's so many CBOs today that are actually working on this issue. Just the other day at the Ida Hut, Pune 22, there's a very beautiful play put up on the lives of Hijras, drawing on the poetry of the first Marathi Hijra poet, and Disha Sheikh. And you have intercollegiate festivals, right? You can have a play like that, being put up. You can sponsor a play like that. You can have trans activists, or you can have people from CBOs come there. They are extremely talented individuals with a lot of creative flair. You can have provide a platform where they can interact and you can get to know more about their lives. So that is also a way in which you can actually familiarize and sensitize others.
Let me quickly answer that as a psychiatrist. I'm always more focused on an individual than community. And my question to myself is that what am I afraid of? Because fear limits my life. Fear limits my experience. Fear actually reduces the enrichment and happiness of my life. So when I meet a gay man, or when I met a gay man for the first time, or when I saw Hijra for the first time, I am very acutely aware of what is happening inside. And most of the times, like most of other people, my first emotion is of fear. And I ask myself, what is this fear about? I mean, am I in danger here? Is this person going to do something to me? What am I afraid of? So one is that physical danger, and second is fear of one's own awakened sexuality. Because here is a person who's wearing his sexuality or her sexuality on sleeve and not being afraid of it, which goes against everything that I have ever been taught in my life. So am I going to kind of go crazy with my sexuality if I associate with them? Is that what is going to happen to me? Am I going to lose control? Or am I actually become someone like that? These are all the fears that people face, and these fears, they don't even realize that fear is one of the biggest fear of anger and hatred. Most people are not even aware that they are afraid. They just feel angry. And I think at a personal level, exploring your own fear will liberate you more and make you more human than anything else. That is why I am in psychiatry. People who are afraid of so-called mad people, they don't even go close to them as if it is some contagious disease. So if I can cross one barrier, I want to cross all the barriers. So at a personal level, that is what I would want to do. And then taking action, affirmative action at a societal level will be the next step of that.
I'd like to actually read one comment which was on YouTube now. Dr. Ketkar has commented, Madam Ketkar, head of the department, social here in this topic. She has suggested that we can add one module and add form for every case on this. Like that as Bhushan sir has just pointed out, fear. That fear can be minimized till the student becomes a teacher or comes into practice. And that can be actually taught scientifically by an home officer.
It's happening already.
It's not happening yet.
It's not
Yes.
like
The thing is,
like in at home is like your approach towards LGBT community is not.
no, that's because NMC is not still prescribed it, but then we are planning to do it anyway because they have given us 40 hours in phase 2 and phase 3. So we have a lot of work with undergrads from this July onwards. I mean, at least in our college. So then that is something that is definitely there. But with regards to, as you said, I know Rina must have been watching, but then with regards to what she said, yes, I think at home. But here the communication skills, I think it is something that probably psychiatry has to take over. So that is something that we have been working on. So as I said, the CBME batch which is coming in 2019 will be coming to us now in the second half of the year. So that is when we plan to take it up. And as I said, as far as didactic information and education, we have been doing it for a long time. So we have been doing it in the lectures. But yes, as far as actually assimilating it into the competencies is something that we require.
Yes, that will do. Thank you.
Thank you. Just have a small vote of thanks.
First of all, I would request Dr. Jyoti Shetty to present the memento to our panelists. Dr. Shukla.
It's not.
Thank you at the end.
On behalf of the Department of Psychiatry, Bharati Hospital, I hereby deliver my vote of thanks to the Bharati Vidyapith team, Cooking University Medical College, for providing us with this venue. I would also like to thank our chief guest who could not be here for the entire occasion, but he was able to take out some time for the inaugural ceremony. I would like to thank GSI and HPQI for their contributions to the event. I would like to thank all the speakers, Dr. Sandeep, Dr. Prasad, Dr. Shetty, and Dr. Shukla. I would like to thank the residents of my department for their contributions. And last but not the least, I would like to thank all the attendees of the event, without whom this would not have been a success. Thank you. Tea and snacks are going to be available outside. Dr. Shukla will be there for the book signing.